So Miguel, as I said, is the chief of pediatric orthopedics in Medellin, Colombia. He was previously the medical director in Venezuela and has been the past president of the Latin American Society of Pediatric Orthopedics. And I got to really know Miguel a little more closely recently at a conference. And I was just impressed with the breadth of knowledge and experience that he has. So Miguel's going to talk about external fixation in children in resource-limited environment. And I think he's going to primarily talk about a certain technique. So Miguel, please take it away.
Okay, let's talk about external fixator in children's and this area here with resource limited environment. We're going to talk about pelvic support that could be a solution in this area. So I have no disclosure for this tech. We're going to talk about the hip, and you know the hip that has a very special joint with a very special architecture, and this architecture could be completely lost in sequelae of septic arthritis, neglected hip dislocation, could be in DDH, cerebral palsy, and myelomeningocele, could be in bone dysplasia and arthrogryposis. And this is the shape of the heads after septic arthritis, the first four types that I have seen in my practice. So I'm going to show you cases with necrosis of the head, necrosis of the neck and the head, fusion, and in some cases, after Pertus, necrosis of a very severe Pertus, or with previous surgery that failed in DDH, SCIFI, arthrogryposis. So the surgery changed a lot, the problem now. So the solution at the beginning of the 20th century was a chance, osteotomy, that is a pelvic support, but with some problem with alignment. So Dr. Gabriel Elizarov solved that problem doing a second osteotomy. In that second osteotomy, you can do the correct alignment of the leg, of the limb, and you can do lengthening also, and you can correct rotation also. So finally, we're going to have an anterolateral oblique plane, and this oblique plane give off muscle balance with a lever arm and support of the pelvis. This support is going to be between the proximal third of the femur that's going to be in valgus, and the support is against the iliac pubis branch in an oblique plane that you can see here. In the second osteotomy, you can do the correct alignment and the lengthening. Okay, this is an example of a patient with a spondyloepiphyseal dysplasia, 16 years old, and the complete loss of the neck and the head. So we did a pelvic support with a monolateral, and we extended to the knee because that knee was unstable. And this is some years later, the patient walking, and he was almost normal. Okay, there's another example of 6 years old with a patient with a septic arthritis, neonatal septic arthritis. And the patient lost the head and the neck, and we did at that age, and the last year, we did a pelvic support, we did lengthening, and to short the time of consolidation. Once we get the length of we desire, we change the external fixator for a plate, and that's the moment when we took out the plate and patients walking without pain, and it's not a normal gait. The patient doesn't have gluteus medius normally, but it works. And that's another patient with a septic arthritis, but that septic arthritis was at 12 years old. and he lost the neck and the head. He lost the head also because there a necrosis of the head. So had a failure of the surgery, and we took out that plate, and we put external fixator, and we closed the facet on the other side, and now he has a shortening of 3 centimeters, but it's working nicely, and we're gonna have to do another lengthening later. This is type when the patient had a necrosis with a septic arthritis, because a septic arthritis of the head, but start to develop a joint between the neck and the acetabulum. So in these cases, like this one here, it was a very big septic arthritis with the lady had a septic arthritis of the knee also, and the facets closed in both sides of the femur. So we have now a kind of a very tiny head, but it's not the head, it's the neck. So we did a pelvic support, we did a lengthening, and you can see here the lady now walking with a correct alignment. The discrepancy now is not 11, it's 5 centimeters, and she's gonna need maybe 2 more lengthening because she doesn't have any physis in the femur. Here's another case after surgery. That's another problem when the surgery fails. Was a DDH, then luxation. They try to reduce, and now we have a necrosis of the head with a subluxation. So we did a pelvic support, we did a lengthening also, and now we have a balance of the new hip, okay? And that girl walks always normal. But we have another problem when we have a fusion. So when we have a fusion, we do a Gilderson, like in this case. So we do a Gilderson, we take out the neck and the head, was a huge necrosis like you see here, and then we do a pelvic support. And the pelvic support is working nicely. That's another case of luxation after DDH, failure of a lot of surgeries, and now after pelvic support and lengthening, you can see the case. That's we don't do a pelvic support normally in cerebral palsy, but this patient had a failure of several surgeries because he's a hemiplegic. So we did a pelvic support, we correct all the deformities in the femur and did the lengthening. So he's walking now. And finally, I'm gonna tell you this case. I was in the medical record of my hospital looking for the shunt osteotomy that my professor did some years ago. And I found this patient that my professor did shunt osteotomy at the age of 8 years old because of luxation of the hip. So by that time, 2008, I had a follow-up of 46 years old. I called the patient was alive, and he came to my clinic, and he had a normal gait, pain-free, normal mobility, a discrepancy of 3 centimeters. And here's the patient walking normally. And now he's walking at 70 years old after 62 years after surgery, because the surgery was done in 1962. Normal gait, pain-free, functional mobility, and discrepancy of 3 centimeters. So looking at all these results I have done and the results of my professors, I can say that the pelvic support is a solution in pediatric hips severely affected, and maybe it's not only a third world solution. Thank you.